Good afternoon and a very warm welcome to this webinar organized by PVI in the Paris studio and supported by Gore. My name is Erik Verhoeven. I work as a vascular surgeon in Nuremberg, Germany, and I am joined by Professor Colin Bicknell from Imperial College London and by Professor Kaki Yeung from the University of Amsterdam. Unfortunately, Kaki is not with us, but for a very good reason. You can see how nicely she's dressed, ready to go and celebrate the Chinese New Year in Amsterdam. The learning, and enjoy it, Kaki, enjoy it. We wish you all the best for this night. So the learning objectives of this webinar is really to discuss the values of large registries, to obviously report the long-term results with the Gore Excluder graft, and also to demonstrate how this graft has evolved over the years in order to address more challenging anatomies, specifically with the proximal neck. We will have 3 presentations. Each presentation will be followed by a discussion, and then we will move to the next presentation. Feel free to send in your questions, and I will give the first presentation. Colin will check the questions and then hand them over so that we can together discuss the learning objectives. So without further delay, I would say, let me start please with my presentation that is really focusing on the long-term outcomes with the Gore Excluder graft. My relevant disclosures include the fact that I am the PI for the Gore C3 study in Europe. As an introduction, I would like to say that we all know that EVAR is a minimal invasive procedure with a lot of advantages, but that we need to continue to work on the durability because that is what our patients need. And therefore, we need to work on correct long-term endpoints as they are listed in my slide. The Excluder stent graft is unique. We've used the Excluder stent graft for more than 25 years now, also I personally and many others. And about 15 years ago in 2010, the graft remained unchanged, but we got a new fantastic deployment mechanism. And this deployment mechanism allowed us to recapture and reposition the top stent, both for level and for orientation. And that changed our life completely. A few years ago, and Colin will discuss that more in detail, we got the conformable stent graft to address more angulated necks. There is an optional angulation control mechanism that will force the graft into the angulated neck. If you compare the 2 grafts, what you see immediately is that the conformable graft has a longer body, but more importantly, a more flexible body that adapts to neck angulation. So my task is to discuss the C3 module of GREAT, and I will also discuss our own experience to give you some examples. This is the C3 module, 13 European centers that included 400 patients in a relatively short period of time. And what you see here is the 1-year results paper that was published in the European Journal of Vascular Surgery. And obviously, the early results were good, as we can expect. Technical success was not perfect. 2 conversions that were due to the learning curve in difficult anatomies where the operators overdid it, so to speak, with the system. If you look at the long-term results, the aortic-related mortality at 10 years was extremely low with 1.3%. And if we look at the device-related interventions, they were also very low with 18% at 10 years. You can see that I also list the slides inside and outside the instructions for use, and this becomes important when you look at the freedom from type 1 endoleak, proximal type 1 endoleak. As you can see, a very good result with 95% freedom at 10 years, but a statistically significant difference in favor, obviously, of the patients that were treated inside the instructions for use. The freedom from aortic rupture at 10 years was 99.2%. Something that has become more important again nowadays is the sac behavior, as we truly believe that we should aim for sac shrinkage. And you can see here that 2/3 of the patients had sac shrinkage and less than 10% had sac diameter increase. So if I summarize the key outcomes at 10 years, you can see a very low number of aortic rupture, an extremely low number of proximal migration, and I would like to highlight the last two again with regard to the type 1A endoleak. You see the same slide again, but to demonstrate that if you treat patients inside the instructions for use with the Gore Excluder graft with the C3 mechanism, you can see that you virtually have no risk of having a type 1A endoleak, 2 out of 332. Outside the instructions for use, if you address more complex necks, especially short necks, your risk of having type 1A endoleak is increasing statistically. And finally, I would like to stress again, as I've done over the last 20 years, that the limbs are really second to none. We had only 3 limb occlusions out of 800 limbs in these 400 patients, and that's an absolutely extremely low number. So I would like to switch now to our own experience to give you some practical details. You can see that in Nuremberg, we used 533 C3 excluders, including 109 CXTs in the last years, and you can see the distribution for the patients. There are confounding factors, to be very honest, and the most important one is the fact that we are not afraid to move to FEVAR when we see a patient with a devious neck. You can see that we did more than 800 FEVARs in that same period. Another point for the numbers is that we excluded in these numbers all the patients that had EVAR with an IBD from Cook or an IBE from Gore. The perioperative outcomes are excellent. We had 9 intraoperative type 1 endoleaks that all disappeared at the first CT scan. 30-day mortality in elective cases is still 0 in about 500 patients, and a very respectable 16% in the acute patients. If we look at follow-up again, long-term, a mean of 62 months, you can see that during follow-up, 6 type 1A endoleaks occurred, 4 limb occlusions, again the same extremely low number, and we had 1 aortic-related death. That was a patient that we treated and converted at 3 months because of an infection. And actually, looking back at the original CT, this was most probably an aortoenteric fistula to start with. If you look at the same long-term outcome parameters, you can see that the estimated freedom from reintervention was 81% at 5 years, and that we also had significant sac shrinkage in about 50% of the patients, and sac growth only in 6% of the patients. To finish my talk, I would like to show you some images. Late failures, we didn't have any ruptures. We had 6 endoleaks, as I told you. 3 were treated with FEVAR, 2 with conversion, and 1 with endoanchoring. And we had 1 conversion for thrombus. And I'm showing you a few of these cases to demonstrate that it was always the anatomy that guided the complications. Here you see even for the conformable and excessive angulation, double angulation. And at 1 month, we had this CT scan with type 2 endoleaks with thrombus in the proximal neck, and we decided to convert the patient with success. This is another patient from the early years. We decided to put in the C3 excluder. Unfortunately, the proximal neck evolved, extension of disease proximally, and in the end, we also decided to convert this patient. And finally, a patient where we decided, because of his old age, to treat him with a simple procedure in a double bubble configuration. And you can see it seemed to work well for some time, but at 5 years we had an endoleak, and this old patient was still alive and doing well, and then we treated him with a fenestrated cuff. And this is the kind of patient with the never-ending story. You can see first an endologics in another hospital, then a proximal cuff and palmas, then relined with a Gore C3, and finally a EVAR. We sometimes have these patients. As long as we can help them, we are happy. Final slides about the limb occlusions, always in bad anatomy. This patient is special because we saw the CT scan and decided to treat him with kissing stents. You can see the image with the one limb on the right that is collapsed by the other limb. Unfortunately, he occluded before coming in and came in with an occlusion, and we decided to do a crossover. This is, again, exaggerated indication in a very calcified, a very narrow aorta. You can see one limb collapsing the other, and that also required a crossover. And finally, this was a patient where we were not liberal enough in putting kissing stents during the first procedure. We saw this, he occluded, and we did a thrombectomy and kissing stents. So to conclude my presentation, I think I can say that the excluder graft is, for us, the leading global workhorse for EVAR in many anatomies and many indications. The long-term outcomes are really excellent, as I just showed you. Inside the instructions for use, very few type 1A endoleaks, and the limbs are really second to none. With that, I would like to thank you for the attention, and I would like to move to the discussion and ask Colin maybe if he has a question, either from the public. I know there are many people watching us, and otherwise, Colin, do you have a question for me?
Yeah.
Or Kaki, of course.
Yeah, we've got some questions for you. Do send them in, though. We've got a screen down here where we can read them off. I mean, what you presented is a huge amount of data from your centre experience and from the GREAT Registry. Should this be normal now, collecting long-term large registries like this? And whose responsibility should it be?
I think it's a shared responsibility of the largest centers and the companies, the medical companies, because we need those data. We cannot aim for randomized data at all times. This is real life data, but we have the obligation to report the long-term results.
And 10 years is a long time.
I know.
What did you expect to find at the start of this registry that perhaps you didn't, perhaps in the context of those EVAR trials that came out around the same time?
Yes, and that's a very good question, because we know that the trials have a very strict selection, and then you tend to have better results. And we were slightly disappointed with the long-term results, but there were older generation grafts. I think it's fair to say that the excluder with the C3 system and the conformable is the only graft that has withstand the time burden, so to speak. And I think if we look at these results of these data, we can again clearly say that we should stick to the instructions for use. And I'm not saying that we always do, but if we go outside the instructions for use, we need to have a very good reason. That can be an older patient where we cannot do something else and where we probably don't want 10-year results, but we can be proven wrong, as I showed in my patients, or patients that really have no other option, patients that are too sick or have a combination of sickness and bad anatomy to have a fenestrated graft or an open repair, because these are not the competitors, but these are the other options. We always have to look at open surgery as an option, and if the neck is not inside the instructions for use, we always have to consider FEVAR. So this is what I think is important.
I think that's an important message. I've got some questions coming in now. If we have a neck of 10 millimeters or 8 millimeters, would you prefer a FEVAR?
Yeah.
Or an EVAR with excluder C3?
It's a brilliant question. I would almost say if the neck is otherwise perfect, which means straight, nothing with regard to calcification and thrombus, and a small diameter, because a neck of 21 millimeters is not the same as a neck of 28 millimeters. So if all arguments are fine and the only questionable argument is a short neck, I would still do a EVAR. I would then probably do it with a conformable because of the long body, and if I had the need later to do a FEVAR, I would have an easier job. If anything else comes into play, I would go for either FEVAR, but again, not forget open surgery. We do more patients with open surgery now if we are not certain about a durable result with whatever endovascular solution.
Which is important for the next question. You're being challenged. My question is, what was the median age of the patients? 10 years for young patients is still not enough.
You're correct. And my answer to that is always the same. The younger and healthier the patient, the better, and inside the instructions for use, the anatomy needs to be to justify EVAR. I'm not against EVAR, even in young patients, but I will never accept EVAR in young patients where the anatomy is not perfect. So as soon as the anatomy is crumbling with regard to the instructions for use, and that's not only a short neck, that's also angulation, that's wide neck, that's wide iliacs, anything where you also suspect a risk, a higher risk of extension of disease in the long term, we would try to convince the patient to have an open repair. Having said that, if the patient is fully informed and he chooses EVAR, we will document it and we will do EVAR. But the general rule of thumb is the younger and healthier the patient, the better the anatomy must be to guarantee durability to avoid late problems.
Yeah, I see a lot of people shrugging their shoulders and holding up their hands saying that we can't do anything about that long-term biological neck dilatation. But it looks like in your presentation, you can pretty much predict who is going to have problems or who is at high risk, at least.
I think we cannot predict that 100%, like anything in life. But after 25 years, we know what is good and what is bad. And the only thing we need to do is to look at the CT scans with a critical eye. Don't see a neck where there is no neck. Don't see a good neck where there is a wide neck.
Yeah.
Don't see something that will hold on forever if there is severe angulation. All these things we know, and we need to take that into account. Kaki, I see you. Do you have a final question?
Well, I have a comment a little bit on your remark, is that actually the excluder conformable has a wider range of instructions for use. So in a shorter neck, like 10 millimeters, and it's not a wide diameter, so below 28, it is within the eye of you to place an excluder conformable.
Yes.
So I just want to touch up on
yes.
that. Yes,
you're right, but Colin said 10 to 8 millimeters.
Oh.
To be very fair,
Yeah.
we officially like to stick to the 15 millimeters, but we've never done a FEVAR initially in a neck between 10 and 15 millimeters. So actually also in real life, we adapt and we say, well, here probably EVAR will stand. But I think you need to take into account the other arguments. But your question, Kaki, is very good to make me jump to Colin's presentation, because he's now really going to discuss the CXT in detail and a study that was executed in the UK in different centers, a multi-center study, and show us the results. Colin, all yours.
Thank you very much. Welcome everyone, Happy New Year. I'm going to talk to you about angulated necks and the CLEVAR Registry, which we ran in the UK. These are my disclosures. So we've known for quite a while now that the angulated neck is a hostile neck. This analysis showed us increased rates of type 1A endoleak and reintervention up to 2 times that of patients with non-angulated necks. And that translates to about a 10% excess in type 1A endoleak between 5 to 10 years. And it's probably because there are conformability issues of older grafts that lead to early type 1A endoleak as the graft is positioned in a highly angulated neck. But it's also because of failure of accurate deployment and loss of that seal zone and reduced neck coverage, which leads to long-term problems, failure at the neck. So the Gore Excluder conformable prosthesis with active control system at the top was designed to try and tackle this problem with angulated necks. Is based on the platform of the Gore Excluder, which has got 25 years of worldwide experience and nearly 500,000 devices implanted in the world. But this device is different because it's more conformable at its proximal end. The proximal end is longer, so it can take a longer bend, an angulation at the top, but it also has active control where the physician can angulate the proximal end of the graft to deploy the graft just at the level of the renal arteries, perpendicular to the center line, and cover all of that available neck. And this is the kind of patient who we place that graft into. This patient's older, comorbid, and he's also urgent because he's symptomatic. So we don't have a lot of choice. But the conformable graft is on IFU for this patient, even with an 83 degrees angulation at the proximal neck, but it's got a 3 centimeter length. We would choose this graft because it's inside IFU, because of that active control allowing that accurate placement, and because it's so conformable, it will take that bend nicely. It's also repositionable still, of course, and the limbs are, as Eric says, second to none. We'll see no surprises in the first part with groin access, the dry seals access on both sides, and placement of the graft. You can see how the graft is straight up and down in this angio image on the left-hand side with the stiff wire in place. But what you do is take out that stiff wire, and then you're able to angulate the top end of the graft. You can see a demonstration of it there. So we take out the stiff wire, replace it with a Terumo wire, or we sometimes use a Terumo Advantage with a long floppy tip, angle the device when closed or partially deployed, and then open the graft fully. You can see it lands snug to the renals, perpendicular to the center line. You can then, I must remember to tell you, you can reposition and you can further angulate with the graft partially open, and then obviously releasing the constraints before the full deployment and placing the stiff wire back in. So what we do then is complete the contralateral and ipsilateral limb, balloon with care around the angulated neck, but then take completion angiograms in 2 planes, I think is important, with no stiff wires in place. So you can see that graft sitting very nicely in the angulated neck with no type 1A endoleak. And to have a look at this graft in detail, the British Society of Endovascular Therapy, along with Gore, started the CLEVAR Registry. We had 12 sites from around the UK, recruiting 105 patients over a 2-year period, but we had 3 lockdowns just because of COVID in that period. The idea of the registry was to report on the device-specific performance outcomes of this device in routine clinical treatment of abdominal aortic aneurysms, and primarily to evaluate the aortic neck area covered. And what we did is we calculated the distance from the lowest renal artery to the upper and lower portions of the graft and calculated the uncovered area from that. We had secondary endpoints, obviously, of technical success and clinical success of this device to 1 year. So these patients were real-world patients. They were of the older age group, 75 to 80 years of age. They had multiple comorbidities and a number of them were symptomatic. There were no ruptures in this group. If we look at the results, what you'll see is that there was good technical success, 96% success overall, 99% technical success in the group on IFU. And what I've done in each of these slides is divide it up into 3 different sections. Group A, which is on IFU, between 0 and 60 degrees angulated and greater than 10 millimeter neck. Group B, which is also on IFU, which is 60 to 90 degrees angulated, but greater than 15 millimeters neck. And I've got a group C off IFU, and these patients are mostly highly angulated or shorter necks. So the technical success was 99% in group A and B on IFU. In the group C, there is 1 type A endoleak and an excess of adjuncts needed during the procedure, 4 aortic extension cuffs, 1 requiring aortic extension cuff and endo anchors, and that's in 14 patients. In the IFU group, there was excellent clinical outcomes we had reported from sites. These are 2 of our cases. The one in black and white is an angulation between 60 and 90 degrees, but with a decent neck. You can see the graft deployed beautifully just below the renal arteries with no type 1A endoleak. The one in colour is a double bend, but even with that graft, getting this graft right up to underneath the renals was possible to the second bend. In our post-operative period, up to 30 days, we had no 30-day mortality. We had 1 conversion to open repair in the off-IF group in group C. This graft was placed and then on the first CT scan had proximally migrated or was found covering the renals at that time. It required open conversion. They survived, but not a slight complication. We had a core laboratory in Liverpool that looked at the aortic morphology data. There are certain differences in the anatomical features, obviously, between the groups, but our primary outcome is the mean aortic neck that remains uncovered. You can see that that's less than 10% in all groups. It's marginally less neck covered in the off-IFU group, but not statistically significant. There were no type 1A endoleaks extra seen in the core lab analysis. From 30 days to 12 months, there was no aortic-related mortality. There was 1 further type 1A endoleak group noted at 12 months in that on IFU group A. The major aortic neck complication and re-intervention there was in each of the groups. In group A, there's that proximal extension for the type 1A endoleak. In group C, there is another proximal extension, which was the type 1A endoleak, which we found originally from the graft deployment. And there's an open conversion in group B, reportedly due to a type 2 endoleak. So, angulation poses a specific risk for the treatment of aneurysm repair. The new devices allow enhanced neck coverage, and I think what our CLEVAR registry has shown us is that greater than 90% of neck coverage from core lab data is present in straight cases and in angulated cases as long as you're on IFU, and there's no difference between the 2. There's a 99% technical success when on IFU with no type 1A endoleaks early, but 1 later on. Of course, we need to survey And we do need to use special caution in those cases off IFU, as there is a number of major complications in that group in only 14 patients. Thank you very much. I hope we have some questions.
Yes, thank you, Colin. Excellent presentation, and you explained very nicely to us how this graft is intended to work, and it does inside the extended instructions for use, but your message is don't overdo it because it stops somewhere, correct?
Yeah, absolutely. I think it's very interesting, isn't it, that the graft seems to perform exactly the same in 60 to 90 degrees angulation if you have a 15 millimeter neck as it does in those straighter cases. But as soon as you take it too far, there are major complications, and in only 14 patients, there's too many there.
Correct. And before I go to other questions, and I'm waiting, of course, for more questions from the attendees, please do send them and I will read them immediately. I have one slightly off the hook question, so to speak. The importance of the flow splitter position in angulated necks.
Yeah.
Do you take that into account? Because I found it very interesting to see that with the longer graft, you can also position the flow splitter below the angulation. Is this something that bothers you and that makes you discuss your graft?
Yes, I think in those highly angulated cases, it's really important that that graft is longer so that it comes around the bend before that flow splitter sits there. And I think it sits much nicer than the traditional graft, actually, which was quite conformable and actually did rather well in those angulated cases. But this has just got those extra features, which means that we're going to be able to make sure that graft is in a good position, take the forces off that graft, and hopefully cover more neck to guard against long-term failure, you'd hope.
Okay, before I have two more questions, but there is a question from our attendees, and it's something we discussed up front a little bit. If conformable has only advantages to the C3, we should have somebody from Gore here, then why is the C3 still on the market? Is there any advantage of the C3 compared to the conformable? Or is it, for example, easier to use? Or is it just for the cost? And obviously, we discussed upfront the regional differences with regard to cost and reimbursement, so we cannot go into detail there. But can I ask you your opinion on that, even with an UK view?
Well, the UK view is that the original C3 is a very good graft, and it is very simple to use, and there's no reason to change in normal anatomy, especially if there is a cost implication to your country or your region. The conformable C3 has a number of extra steps to it, and they're not that tricky, are they?
So,
but,
so it's fairly straightforward.
It's fairly straightforward.
Okay.
And I mean, if they got rid of the old one and just used this one, I'd be perfectly happy.
Yeah, I can imagine that. We moved a little bit in that direction. Kaki, can I ask you your opinion on this question? Should we get rid of the C3? If you were the new president of Gore, would you say we're only going for the conformable, or would you like to have both next to each other?
Well, there's more data and long-term data, of course, available of the C3. However, I have changed my inventory. Like for acute cases, we only use now the conformable because it's always challenging. And I think challenging cases, the C3, the conformable excluder is better. So that's why I usually, use the conformable excluder right now.
So like in our hospital, you have a stock of CXTs for acute and semi-acute cases?
Yeah.
Okay.
So the conformable excluder for the acute cases on stock, definitely. Yeah.
Okay, thank you. Now, I'm asking you the question. It's a longer body, it's more flexible, and you have a system to angle the body.
Yeah.
Which one is the most important in your opinion? I have a very strong idea about that, but I'll listen to you.
It's the conformability. It's once you take that stiff wire out and replace it with a Teruma wire or something similar.
Or just take it half out.
Just take it, yeah, you can just take it
We
out
do
to
that.
the flexible side.
Yes.
Actually, that graft then conforms very nicely to the angulation in the most part. And that of the three parts, funnily enough, although the active angulation, the active control, seems the most attractive when you first listen to it, it probably is not as important as the conformability and the fact that you can now have that long graft coming around the back angle.
Okay, there is Kaki and Colin. There is a bit an unrelated question to the conformable versus C3 because it's valid for two. I'd like to know all your thoughts and experience on managing aortic neck thrombus. With the C3 conformable is written, but so what is your view on aortic neck thrombus? How do you handle that with regard to indication and maybe also with regard to treatment?
When we get thrombus, I worry intensely. I always over-investigate the distal part of the graft to make sure it's flowing properly and make sure we're not missing anything, you know, with ultrasound and
I mean thrombus in the neck before the treatment.
Ah.
So the contraindication or the relative contraindication of thrombus in the neck. That's what I.
That's what you took.
That's how I read it.
I was still on the post graft looking thrombus in the neck.
Well, yeah, I don't know actually because
it's a diseased neck.
Yeah.
And I'd go back to all of your comments earlier. You can't make excuses for diseased necks. You have to think about it carefully, and it will depend on the clinical aspects, the anatomical aspects, and your situation at the time.
So before I ask Kaki the same, well, please go, Kaki. Tell us, how do you handle thrombus before a treat and after then? Then we have both. So how do you see thrombus in the neck? A contraindication?
No, I think it depends on where it has to seal and how much the contact will be at the wall. So, and also if you look strict into the IFU, there's also not much about thrombus. So I think if you think there is seal enough, then you can have, you know, even when you have 75% thrombus, you could still, you know, place an EVAR if there's enough contact points below the thrombus or somewhere else.
And you would love the thrombus to be a little bit away from the renal arteries, I guess.
Of course, once you know, you have to protect it. It's the same when you do a CRAP case or whatever. You can put in balloons if you want to protect it, but it depends. You have to be very careful, of course. And when you, I think when you deploy the graft, it's fine. But it's not too much movement. So of course it's you can replace the graft. That is what Gore says. But you don't want to go up and down when there are thrombus. You just deploy it once, and when you are going to balloon it, be a little bit more careful. So that's it. Yeah.
So the indication is somewhat mitigated. You need to be a bit more careful, and then you need to elaborate a strategy and work it out very carefully. Now, I showed a case where we had thrombus in the neck after the C3 excluder was implanted. I think this is an absolute rarity. Have you seen that in the body of an excluded graft? Or can we say this is the exception?
It's a very rare event.
Very rare, yeah.
Okay. I think, Colin, if you're okay, I have more questions, but I think, is the conformable suitable for PMEC? Last question, quick answer.
No.
The answer is no. I think I wouldn't do that in a PTFE graft to make holes in it.
We did do some studies looking at making holes in and ballooning them up, and the PTFE did tear.
And it's more difficult to reinforce them, I think.
Yeah, I'd imagine.
So I have never done it, to be fair. So with that, Colin, thank you very much. And Kaki, I would like to move to you because we don't want to hold you away from your Chinese gala tonight. You look beautiful in your gown. So can we ask you to give your presentation on the GREAT Registry with respect to other registries, and also the new TOGETHER Registry, which will be having different modules with the different products. So Kaki, all yours.
Thank you for the introduction, Eric. So I'm going to talk about the value of long-term registry data, insights from the Gore GREAT Aortic Registry, what we heard about from Eric a little bit, and how it progressed to the Gore TOGETHER Aortic Registry. So these are my disclosures. So the history of the global registry for endovascular aortic treatment, the GREAT Registry, started actually at enrollment in 2010, and a 10-year follow-up to be completed next year in 2027. It is a real-world data collection covering 130 sites over 14 different countries, and it looks at TEVAR and EVAR, so the Gore tag, and also the Gore Excluder and the iliac branch endoprosthesis. If you look at the GREAT Registry, it is globally one of the largest registry if you compare it to the others. So almost 5,000 patients were included globally with a follow-up of 10 years. And Eric just presented the C3 module in about 400 patients, but there are also other modules in these 4,600 patients from other PIs available. And here you can see that mostly of the patients were men that were included, and they were mostly white, some of them Black African American, and very less Asian population. So when you look at the benchmarking, the EVAR and TEVAR outcomes, the freedom from aortic mortality was over 95% in EVAR and just below the 90% in TEVAR, which is great. And if you look at the reintervention outcome, 10-year freedom from device-related reintervention was at 85% for EVAR and about 80% for TEVAR. So the lessons learned from the GREAT Registry was a lot, actually. There were over 30 publications in 9 international journals and 4 all cohorts publications available. And that means that the GREAT Registry gives us studies that shape clinical practice that we use now. One of it is the great confirmation that the IBE devices were very well performed for the endovascular treatment of iliac aneurysms associated with aortic aneurysms, with reintervention rates of 5% in 6 months only. Then, if we forward it now, we progress into the Gore TOGETHER Registry, and that's the current next generation Gore device option for aortic pathology. It has unique modules and sites selected for individual modules. It also collects images for analysis, and that is something very novel. It builds on the great learnings, of course, and it is, again, a high number of patients inclusion. 3,355 patients to be enrolled in the first 3 modules globally at 179 sites. And it's one of the largest registries conducted by Gore with, again, follow-up of 10 years. Oh, sorry. It is an umbrella, actually, of the Gore Excluder conformable, the iliac branch endoprosthesis, the Gore tag, and also the TBE that has been started, but also can be added a new aortic product. And imaging, again, data to Gore with follow-up up to 10 years. So these are the models that I will discuss today with, but in the IBE and Excluder conformable, about 2,000 subjects will be included in US, Japan, and also New Zealand, Australia, and Europe in 96 sites. The CTEC is 1,200 subjects and the TBE 155 subjects. It started at enrollment actually last year, and the follow-up, of course, continues for a longer period. If you look at the regional principal investigators, then you see that every model and every region has a different PI. I'm the PI of Europe for the Excluder conformable and the IBE. So the devices, again, it is a prospective observational post-market registry. And like I said, around 2,000 patients implanted, subjected, divided by device type for the TOGETHER Registry of the Excluder Conformable and the IBE, and 110 clinical sites representing in North America, Europe, and Asia Pacific regions. So the primary outcomes are technical deployment success, all-cause and lesion-related mortality, device-related adverse events, and the secondary outcomes are access-related complications and all types of other complications, but also incidence of erectile dysfunction or buttock claudication and quality of life measurements, which is very novel. And the enrollment currently is pretty good. We have 705 out of 1,700 patients already included in excluder conformable. And in the IBE, it is about 248. And in Europe, actually, it already closed. So it's only for the US that can be inclusions followed up in the IBE enrollment. If you look at the subject, most of them were 97% were primary procedure for endovascular treatment, and re-intervention only in 3% that were included in this registry. And it was equally divided between the US, Europe, and Asia for the case planning of the abdominal aortic aneurysm by region. And we look at the sex, it was a little bit the same as in the GREAT Registry. Mostly of the patients were male compared to female. And 1/3 is an IBE group, and the other 2/3 is actually from the excluder conformable group that were now included. If you look at the demography, then you could see that the US has mostly white patients included, and Europe either multiple races or unknown, which is pretty nice if you look at the data maybe later. And in Asia, we have around 300 patients already, so 99% were Asian population. And that is also something novel compared to the GREAT Registry. So TOGETHER Registry uses some normal statistical analysis like descriptive methodologies, Kaplan-Meier survival analysis, Cox proportional hazard models, and also contextual comparisons. However, this real-world evaluation of this current or next generation core aortic devices has its high power in numbers, wide range of geographies and patient populations. By adding the data of images, it means that there is possibility of enhancing research opportunities with artificial intelligence to look at all that big data and also to analyze all these images. It has a patient-centered outcome like quality of life next to the all-cause mortality and aortic-related mortality. There's also device-specific, aortic segment-specific outcomes added to the database. And it has the opportunity, I think, to shape the future now for the endovascular aortic therapy with an observational nature and long-term follow-up. So I would like to thank, if it advances the slide, it doesn't work anymore. Actually, it's the last slide. I'd like to thank Suhuan, the PI of the US, that helped me a bit with the presentation slides, and of course the team of Gore. Thank you.
Thank you very much, Kaki. Excellent presentation, and obviously a very interesting one because I see two different levels in this presentation. On one side, I see the MDR or the medical device regulations coming by, where a company now says we need to recertify our products every 5 years, so we better be early and have a good registry to have these data available. On the other side, and that is what I expected from you, and for which I congratulate you, is the pure scientific, also in terms of AI future and possibilities. As you said, you now will have probably also far more Asian patients, and that makes it very interesting. And with the imaging and the combination towards AI to make us predict and see complications earlier, I think that's an important issue. So can you comment on that or discuss that for me?
Yes, so thank you for this question or comment, Eric. So I think it's very important that we have imaging data, but also patient-centered outcomes like quality of life or erectile dysfunction, because these are things we haven't analyzed before on a large manner. So this is a unique opportunity to use AI to analyze all these images, to have big data and long-term follow-up with all these patients. And it's great that these kinds of registries will exist and are existing right now. So I like to thank everyone that there is an opportunity and that we are all collecting these data together. That's why it's a TOGETHER Registry. And in this area of time, I think this is so important to have high quality data, and then we can deploy indeed some AI on it to predict outcomes. Yeah.
So together is not only all the grafts from Gore together, but it's
No.
also the users together to make a combined effort to produce good data that help us for the future. I would like to ask the attendees to send in questions to any of us. We will try. We have another 4 minutes before we slowly close. Colin, you had a question for Kaki or remark?
Yeah, so the collection of images is truly novel and truly exciting, isn't it? The first step, I guess, is to analyze those images and understand how accurate an AI system is on a large scale like this. It could make a huge impact on every single randomized trial that has a core lab in the future, or every other single registry. Do you see a really big future from this, like I do?
Yeah, so of course there are many more large databases. So, but the unique thing about this is that it's all has been the same graft implanted. It's all from Gore, all excluded conformables, or the TBE, or the CTEC. So everything is actually the same device. So you can yeah, look at the long-term follow-up and initial analysis of these devices. So that is the difference, because I think there are larger registries that are there with different kinds of devices, but not with the same indication or the same, graft implanted. So I say this is a great opportunity that we can use AI right now for it. Yeah. But in your answer to validate algorithms, it doesn't have to be within a graft or not within a graft. So from the Vascular data, we have 40,000 patients included, and we can make very easily aortic segmentation and validation on these cohorts.
Brilliant.
So, Kaki, thank you very much for that. And can I ask you, how far are we with AI to predict which graft or technique will work in an anatomy and which will not? We discussed it before and discussed all the little arguments that we've been discussing for years: diameter, thrombus, angulation, tapered neck, etc., etc. Do you think with imaging we will come to a point where it will not be the surgeon, but the artificial algorithm that will tell us, don't do that in this patient because it will not be durable? After all, we are in a durability webinar.
I think yes, because one of the things that we can think about is the endoleak type 2. It's a big question why an aneurysm is still growing, why the type 2 is still there. So there are a lot of unanswered questions, and some necks will grow larger and some don't. So I think that advancing image analysis with AI will give us more answers, but we do not have to forget the biology of the patient. So we do also have to look at the genetic palette, the omics palette, and the activity from the patient. So it's actually not only imaging. Together right now, because our eye can only look at the diameter and treat diameters, but or lengths, but later with AI we can treat more. We can have a more classification based on imaging, but also based on the patient itself, like what the gene palette is or the phenotyping. Yeah. So it's going to be more personalized.
I agree completely with you. And you discussed biology, and I like to discuss inflammation and neovascularization. My very good friend Thanos did 2 conversions or semi-conversions for type 2 endoleak, and what he found was the so-called moya-moya endoleak, or the complete revascularization of the aortic wall that creates an inflammation and a sac growth. And we are far from understanding all these processes. As a pure clinician, I am always saying, why is one aneurysm shrinking away in a standard EVAR or in a triple fenestrator, and why are others causing us trouble for the years to come? So that's very interesting.
About the sac regression, which is a biological process. And these patients live longer, but is that because of less reintervention? They said in a sub-analysis it was not a reintervention. So that means that it's something about thrombus load or something else. And we do know that patients with a large aneurysm has a lower life expectancy. So we don't know what the chicken or the egg is. So is it the thrombus load that causes a high inflammation or the other way around? So I think there's lots to learn.
Thank you, and I totally agree too. I must say that we all know that Gore has got fantastic products, but that they are sometimes slow with bringing these products on the market. And I really hope that with the added TOGETHER registry, we will probably move forward together with Gore to have some products earlier on the market. I can give you the example of the TBE that I deployed maybe 20 years ago in a pig in Flagstaff, and we've been waiting a long time for that graft, and the same maybe with the new generation IBE. I think we covered most of the topics. There are no more, there are more questions here. I don't know. Can I see something? Why did you use endo anchors on EPTFE, Colin, the PMEG and the PTFE again?
The endo anchors that go in a spiral configuration and jam it at the end seem to be quite safe on testing in that Gore graft and can be used. The PMEG, I mean, I don't really know the answer, to be perfectly honest with you. I've never done it, but we have made some holes in and they did tear. And I don't think we can be reliant on that. And most PMEG studies have come out with woven grafts, haven't they, where you get a stretching of the weave with a balloon. That's all I know.
Thank you. Thank you, Colin. I have a last question for you, Kaki. I mean, people are suddenly interested in AI programs in the aortic space that you can use in practice, or computational fluid dynamics. Can you say a quick something about how space may help us in the future, and whether you include CFD in the AI algorithms?
Well, CFD, we have already done CFD with AI, so you don't need computational fluid dynamics anymore from finite element analysis, but you can just do it or estimate it by AI. And I think, yes, you have to add it up because it says something about the vascular stress to the neck growth, because a growing of an aneurysm is not only, at one side, but it grows at different sides. So I think, yes, it says something more than something dynamic about instead of a static image. Yeah. So yes.
And are you planning to go into space soon to learn more from them to use it in AI?
Well, I don't know if they allow me in space, but yes, otherwise I would go.
I'm sure you would say yes. Well, with that, I think we are ready to end this webinar. We have exactly 1 minute left. So first of all, I would like to thank PVI and Gore for the opportunity and the support. I think it's been a wonderful hour. We certainly enjoyed it. Kaki, I hope you enjoyed it too. I would like to thank you, Colin, for being here and supporting me so that we could do that together. Kaki, we wish you a wonderful evening and a wonderful Chinese New Year. And obviously, I like to thank you all. We know many people were registered, and that makes us very happy. And I would like to thank you all for being present and in the end for the many questions. So with that, I would like to close this webinar. Again, Kaki, a wonderful evening, and Colin, safe return, and see you soon. Thank you.
Thank you.